Welcome back to Medical Monday. I'm here with Dr. Nancy Peacock from Tennessee Oncology, and we're talking about breast cancer tonight. Certainly you know someone who has been affected by breast cancer. I think we all have, whether it's been yourself or a cousin or a friend or a loved one. And so this is a very important show to learn some facts, learn about what's exciting on the horizon of treatment, and that's where I want to start. What is exciting right now when it comes to breast cancer treatment? What's out there that's like, ooh, this may work and do really well?
Well, we're really looking, unfortunately, it all involves treatment of metastatic disease, but we're really looking at some new treatments that may help our patients with metastatic disease. And this doesn't just involve breast cancer, but also involves a lot of other cancers using special antibodies that actually help your own T cells go after cancer cells. So that's been really revolutionary in the last 2 years. People have already seen the ads on TV for the drugs in lung cancer, and we're starting to use similar drugs in breast cancer. Again, because right now these are only approved in metastatic disease, it's going to take a little while before we use in the adjuvant setting. And adjuvant means treating women who've had their small breast cancers removed, or neoadjuvant setting means treating them with systemic treatments before their surgery, but and those are women that we're treating with curative intent. So we're hopeful that once we move these drugs and find them to be effective in the metastatic setting, they will be very effective in the adjuvant and neoadjuvant settings as well, so that we can prevent them from ever coming back in the first place.
And that is a big concern. It's not just getting well once you have that diagnosis, but staying well, because breast cancer can come back, and sometimes it's more likely to.
Right, and I think that's one of the biggest things that we worry about with breast cancer. You know, you can't always just predict the risk of it coming back. You can't predict who that's going to happen to, and so women know that, and so they always live with that fear just a little bit. It gets better over time, but it never goes completely away, and that's one thing we really try and talk about, because I want them to get through their treatment and get back into their lives and be just as normal as they ever were before. But I think that they are so fearful, and rightly so, that they won't be able to do so many things they did before. So that's, I think that we're really looking forward to seeing those drugs come along in the breast cancer arena. And then we're seeing a whole new group of drugs in HER2-positive breast cancer patients. So women have different markers on their cancer. The ones most people know about are the estrogen receptor, the progesterone receptor, and now this funny new one called HER2. Well, really all that these things stand for is that they're protein receptors on the cancer cell, that if we target them with specific drugs, we can turn the cell off and make it quit dividing. Cancer cells are unregulated. They grow unproliferated, or proliferating uncontrolled, without the usual cellular controls to stop their growth. And so trying to find these new medications to make the cells stop growing is really what it's all about. And so the first drugs that we had that really did that were drugs like tamoxifen, and now drugs like Arimidex and Aromacin and Femara, things that target the endocrine-sensitive breast cancers. And then we've got drugs for HER2-positive cancers as well.
What about clinical trials? I know that Tennessee Oncology really likes to have their hands in that and have it here at home. It's not that we got to send you far away and you go try this over here. It's right here.
Yeah. No, we have a great partner with Sarah Cannon, and the doctors that work in the Sarah Cannon Research Institute are partners in Tennessee Oncology, so we have a great working relationship. There's a lot of education that goes on. The folks that work in the research part of our group work very hard to get up and coming clinical trials so that they're relevant, they're important, they're cutting edge, and yes, we do them in our clinics. I think that we have access to those for our patients. It takes a little bit more work to have a patient enroll in a clinical trial. Not on my part as much as on the patient's part. They have to be willing to trust that process. And I think that, again, if we could cure all cancers, we wouldn't need to do clinical trials, but we can't. And so these are really important.
Do you think a cure is possible, or is it better management that is ahead for us?
Well,
that's a loaded question, isn't it?
That's a great question. I think we will be curing some more cancers. I think there will still be better management of others. And you know, it's interesting because we've seen a lot of great treatments in some of our hematologic malignancies, some of the leukemias and lymphomas, where the whole landscape has changed with those diseases, and some of that is because we're curing them. Some of that is because we're managing them better and smarter. And I think the same thing will be true in our solid tumors like breast cancer and lung cancer.
We have a caller. Let's talk to Jane here. Good evening, Jane. Thank you for being with us tonight. What is your question?
Hi, I was just wondering, you know, I thought I read somewhere that because, you know, there's more targeted cancer practices that for specifically breast cancer, does that mean that there's less mastectomy in recent treatment? You know, I mean, that's the thing that we see a lot portrayed on like television and whatnot, is that's the scariest and hardest part sometimes for a breast cancer patient. I just wondered if there are more targeted treatments like the T-cell treatment or things like that, if there's less mastectomy.
All right, thank you, Jane. Great question, because I know just from friends who have gone through breast cancer, the big question is, do I do a lumpectomy? Do I do a mastectomy? What should I do? And they're torn back and forth, and you get advice from so many different people.
Right.
What is the reality these days?
So that again, this is a fairly complex issue, and I think that with some of the targeted therapies, not the T-cell therapies yet, but with some of our targeted therapies, we are able to give preoperative treatment with the intent to shrink the tumor enough for a woman to go through a lumpectomy instead of a mastectomy. However, there are several other things that go into play here. One of them is that there are some tumors that just aren't amenable to lumpectomy, that they may be multifocal in several places within the breast, and so lumpectomy just won't give a woman a good cosmetic result. The other issue is that some very young women, if they have a lumpectomy, they worry that they're always going to be worried about when the next shoe is going to drop. So, am I going to have another breast cancer the next time I go in for a mammogram? The data tell us that a woman survives her breast cancer just as well if she has a lumpectomy versus if she has a mastectomy. So the risk of systemic recurrent disease is the same no matter what procedure she chooses. Survival is the same no matter what procedure she chooses. But a lot of women don't want to go through the rest of their life worried about it.
There's a mental component.
Huge, yes. And that's important because, you know, if you're 35 years old and you've got a million things to do, including chasing children and working and, you know, caring for your parents, it can be really, really hard. You don't want to go in for those checks all the time.
No, and you don't want to feel like you have this black cloud back there perhaps following you all the time.
Right, exactly.
Are there, if you choose that mastectomy route, are there considerations for your health going forward if you had kept your breast that would be different?
Well, I think that the whole issue with reconstruction can be a little tricky for people. Young women most definitely want to have reconstruction. Older women, not so much. Although that's kind of a blanket statement. My colleagues, if any of them would be watching, would say, no, that's not right. But a lot of times, older women say, I just don't want to fool with it.
Yeah.
I'd rather get on with my life and not worry about multiple surgeries. But no, not in terms of overall health. I don't think so.
You talked to me earlier about personalized medicine. It's kind of this buzzword in the medical industry. We also see it, you know, in different places now. Tell me what that means.
Well, I think that what we're looking for these days in cancer is to find mutations that the cancer cell has acquired that we can exploit, find a drug for, that'll turn that cell off. And so we're doing it a lot. We've done it in breast cancer for a long time. We've done it in some of the chronic leukemias for a long time. We're doing it in some other solid tumors like lung and colon. A lot of times the applicability is mostly in metastatic disease, but it's always been in the postoperative or preoperative setting in breast cancer. So we're really looking for those markers on cancer cells more than we've ever been able to do, because we can identify them in the DNA. Scientists have mapped out the genome so they know what's normal. Now they know what's abnormal. And we can find drugs that go after those markers.
So it's not you have breast cancer and it's this big bubble. It's this is the kind you have,
Right.
and this is how we treat this very specific type.
Exactly.
Okay,
Right. That's
So
exactly right.
Be able to boil it down a little bit better than what you could.
And then you don't guess so much. One long-held tenet in oncology is you want your first treatment, metastatic disease, to be your best treatment, because that's going to give your patient the longest duration of response. And so, again, not in somebody you're treating with curative intent, but somebody you're trying to manage their disease better, makes all the difference for them.
Let's talk about age ranges. What is most typical when it comes to breast cancer? When do you have to worry the most, I guess?
Yeah, so believe it or not, women between the ages of 55 and 65 have the highest risk. They're in the demographic that has the most breast cancer. But we all hear so much about young women with breast cancer.
Yeah.
So, I think that when a 40-year-old develops breast cancer, it's pretty unexpected, and all her friends know and gather around. Her family knows and gathers around, and so it's more of a shock to us as a community. When older women develop breast cancer, they may be smaller, they may be easier to deal with, and so it's not quite as shocking in their life, because maybe they're not working so hard to develop their careers, their children are grown, they don't have as many responsibilities. It doesn't make it any less serious for them, but it just points to a different set of problems that you have to contend with.
Okay, fair enough there. Let's talk about I just have to believe on a personal level, when it comes to prevention, what do you see with that? What can I do now that I'm healthy and I'm doing well? What can I do to prevent getting breast cancer, or at least do my best to prevent it?
Yeah, well, that's a great question, and this is such an important piece of taking care of women. I think that the rates of obesity in this country are playing a role in some of what we're seeing with an increased risk of breast and colon cancer. It's not just my thoughts. I mean, these have been borne out in trials, in epidemiologic trials. And in fact, the American Cancer Society first reported on this in the 70s with their cancer prevention program. Unfortunately, maybe they didn't have the marketing they needed. I don't know what happened. But you'll hear, and you can read it on their website, 10 servings of fruits and vegetables a day, more vegetables than fruit. Vegetables don't include potatoes, they don't include corn, they don't include lima beans. We're talking about leafy greens and things like that. It doesn't mean you can't have animal proteins. Animal proteins can be very good and very healthy for you, but the base of our diet should be more plant-based. And then when we're eating grains, they need to be whole grains. This whole processed food business has really set America back, I think, and we've paid the price in terms of obesity rates, but also increased cancer rates. Wait a minute, you're talking about obesity. What does that have to do with cancer? Yeah. Well, here's a simple example. So in women who are overweight, they have every fat cell we have has cholesterol in it. Cholesterol is broken down by a series of enzyme reactions to postmenopausal circulating estrone and estriol. If you're premenopausal, you have a higher circulating estradiol levels, but if you're postmenopausal, you have higher circulating estrogen levels. We know that if your endogenous estrogen levels, that your estrogen levels circulating in your body are higher, your risk for breast cancer is higher. So the more fat you carry, the more estrogen essentially you carry, and the higher your risk for breast cancer.
That's putting it pretty plain and simple.
Right.
Yeah,
right.
That makes a lot of sense. So you just got to take care of yourself. Beyond the obesity factor, do you see anything else that, and what we put into our bodies, that we just have to really do to hopefully prevent going down that road of breast cancer or any kind of cancer?
Yeah, well, I think maintaining a lean body mass, it all starts with your diet, and then exercise is important too. That same prevention study that the American Cancer Society put out also said that for Americans to have the lowest cancer rate, they need to exercise. I think it's 140 minutes a week. It's a lot, but that means getting your heart rate up and going out there 4 or 5 days a week. Nobody's perfect. We don't want a bunch of marathon athletes, but we do want people who know how to advocate for themselves and take care of themselves. We do want people to know how to go to the grocery store and pick out foods that are helping their bodies and not hurting their bodies. So this is a huge and important topic. It will make a difference. It doesn't make a difference in all cancers in terms of reducing the risk of recurrence. It definitely makes a difference in breast cancer and reducing the risk of recurrence once a woman's had breast cancer.
Wow, that's a big impact right there. All right, we're going to take a quick break. When we come back, more of your phone calls. Give us a holler if you have a question about breast cancer tonight. We would love to hear from you. 615 888-737-PLUS is the number to call. We'll be right back.